I was going to say, my name is Fotis. I'm one of the Echo Fellows. We're going to be talking about diastolic dysfunction. And I ask everyone to just relax and take a load off and try to absorb some of this dense material. I have no disclosures. Learning objectives. So I'm going to describe a little bit about the cellular process of diastole because I think that's important to understand. I'm going to outline the phases of diastole briefly and how they pertain to filling pressures of the left ventricle. I'm going to describe the echocardiographic parameters that's used for the assessment of diastolic function. And I'm going to review a little bit about the guidelines about measuring diastolic function. So like I was saying, diastole is defined as a period between the closing of the aortic valve and the closure of the mitral valve. And I say that specifically because I'm going to show some images later because it's a really important concept. But at the cellular level, and if you throw back to your biology days, you'll see that there's this concept of this sarcomere, right? So it's a part of the myofibrils. And this is basically how the muscle contracts, how any smooth muscle contracts. In this particular image, you'll see that there's the kind of actin-myosin area here in blue, where in systole, as this whole sarcomere shortens, you can see it's a sequential opening and closing of those myosin and actin heads that are both trying to shorten the sarcomere length. And I'm going to bring everyone's attention to the little red triangles at the end here. This is what titin is. And titin protein is actually, you can think about it like a spring. So when these two sides slowly come together in systole, it shortens and that spring causing potential energy. And then when at the end of systole, and you don't have any more force bringing together those actin-myosin filaments, the titin is going to be the thing that springs open the sarcomere for the next cardiac cycle. And that's really important. What we see here, though, and a couple of things that I wanted to point out is that this process is not just a passive process. It's not just a process made entirely by the passive unloading of the spring of titin. It's an active process. It requires ATP. Things need to phosphorylate to come off of their binding sites. And so it is an important mechanism to understand that whatever can affect systole because of calcium handling and other aspects of sarcomere shortening can happen in diastole. So the problems that we think about where we have patients who are, have calcium channel blocker overload or have diastolic function, diabetes can cause issues with your calcium handling. Many things can cause calcium handling issues in the body, and diastole is not something that's shielded from that. It's not just a passive process. Like I said previously, titin is also one of those important genes, important proteins, because it is the primary driver of stiffness in the myocardium. It is the thing that drives how stiff the myocardium is, and age-related changes to titin as we get older can also affect diastolic function. So the diastolic function of someone who's in their 40s as compared to someone who in their 80s with no other primary cardiovascular pathology will be inherently different based on how the titin gene is created and senile changes therein. Another important factor that regulates the stiffness of the left ventricle or the cardiac myocytes is the expression of collagen 1. And in fact, there have been many updated reviews on diastolic function talking about expression of certain genes that are either upregulated or are silenced in heart failure that also can affect the elasticity both of the titin gene and the collagen gene. Needless to say, it's complicated. And so like I was saying, it's an active process. So in systole on the left, you have the yellow calcium binding to the purple little blob there, which is the troponin that moves over and has conformational change of some of the proteins within the actin-myosin beds, and it exposes this myosin binding site. And then the actin and myosin can do their jam by opening and closing or shortening that sarcomere length. But similarly, in diastole, the same conformational changes, the same reuptake of calcium into the sarcoplasmic material, reticulum, which requires ATP, and it causes a series of conformational changes that stops that function and allows this more, active, but still in some ways mechanical motion of unloading of the ventricle. And of course, we talk a lot about, in cardiology, we talk a lot about the Frank Starling mechanisms, and preload and afterload. And this is in some ways very similar to that. What we can understand is that preload is something that kind of stretches these sarcomeres, and it causes the potential energy to allow for systolic ejection. And it has a very characteristic association between force and length. So diastolic function is, like we said, it's very hard to talk about diastolic function without bringing the Wiggers diagram here. But what I will say is, so in the middle column, I don't think anyone can see my mouse. In the middle column, we'll see the end, so the diastolic part of the cardiac cycle on a Wiggers diagram, where you have the blue line on top, which is your aorta, and then you have your red line, which is your left ventricular pressures, and then you have your, mustard line, I guess, which is your left atrial pressures. But I want to bring everyone's attention to the point where there's a difference between the aortic closure and the mitral closure at the top left box. There's a small two small hash lines on the left, and that phase is called the isovolumic or isovolemic relaxation time, okay? And that's the time when there's no changes or minimal changes in volume, but there are dramatic changes in pressure. So you can see when the aortic valve closes, the LV pressure continues to fall below the left atrial pressure. That's when the mitral valve will open and will fill the left ventricle in diastole. In the bottom, in comparison to the Wiggers diagram, because we're talking about echocardiography, is an M mode that we see both of the aortic and the mitral valve, and they're kind of done in unison. And so what it's trying to show you, again, is that there is a difference in time, the IVRT, or the isovolumetric relaxation time, between the aortic closure and the mitral opening. So when I said diastole starts at aortic closure, it includes that time before mitral valve opening. And similarly, diastole ends when the mitral valve closes, not when the aortic valve opens. So that's kind of an important little distinction to make. And so on the right, you'll see a combination of the volume within the left ventricle over time. And you will also see that in regards to the flow through the mitral valve, which we see on our Doppler tracings. And so there are 4 phases of diastole. There's the isovolumetric relaxation phase, which we've already talked about. Then there's the early diastolic phase, early diastolic filling, which you can see on the right side as that at the change from end systole up into that first plateau where it says diastasis. And that correlates well with the peak of your E wave, which we see on our Doppler on echo. Then there's the diastasis phase, which is basically a phase where there's not much change in your volume. It's a Greek word. It kind of talks about the time between 2 times. And then there is the atrial contribution of the ventricular filling, which again is variable depending on a lot of things, including arrhythmia, including LA size, etc. And then lastly, there's the closing of the mitral valve, which dictates the end of diastole. So those are the 4 phases of diastole, and it's important because we're gonna kind of focus in a little bit on the isovolumetric relaxation time and the pressure changes in that left ventricle as it's going from the end of systole to the beginning of diastole. And so many of you astute who are still awake at 8:15 will wonder, well, why do we care? Why can't we just use those parameters that I just talked about to give us a sense of what diastolic function is? Well, diastolic function and diastolic filling are not entirely the same thing. There's a lot of things that can affect your diastolic filling, and it happens to be a kind of a little bit of a challenge to tease out the differences between the two and how we can really get to the sense of what is the filling pressure, what is the diastolic function, how do we marry those two concepts together. The top graph here is trying to explain a concept where, you have your normal E's and A's. So the E wave is, like we said, that passive filling phase, and the second part of diastole. And your E and your A are affected by your preload. So the more preload you have, the more stretch you have on the myocardium at the end of diastole, which usually constitutes more volume in the end of diastole, there are going to be changes to your inflow velocities. So we're really talking about the fact that we would like to, in ideal circumstances, use the flow to guesstimate a pressure. But we see that the flow is actually going to be dependent not only on itself, or i.e. the interactions between the left atrium and the left ventricle, but it's also going to be hindered by other parameters like heart rate, like stroke volume, like regurgitant volume, and like preload. And so we really have to find something else to bridge that gap. There are factors that can affect different parts of the diastolic filling, and so they kind of separated two concepts out and said, well, there's the early diastolic filling phase and the late diastolic filling phase. The early phase is going to be affected more about pressure changes. So changes in your preload, like we said, will affect the initial pressure difference. So keeping all left atrium pressures the same, if you have two different ventricular pressures and diastolic pressures at 10 millimeters of mercury and 20 millimeters of mercury, the driving pressure or the difference between the LA and the LV at the early diastole will be different. By definition, they will have different amounts of forces driving flow. You can also have changes in your transmitral flow rate. For example, the typical problem exists with mitral regurgitation. So if you have someone who has mitral regurgitation, some of their stroke volume is going back into the left atrium. And as such, the flow through that mitral valve is higher than what it would normally be like because there is a regurgitant volume. And so that's increasing the preload per se of the left atrium and can affect in many ways the driving pressures across the mitral valve, which basically just muddies the water. It's harder to make an interpretation on that. Lastly, you can have changes in atrial pressure. It can be either, again, like diastolic pressure, or you can have your V waves like we talked about, or you can have other issues like atrial fibrillation, or some people who have atrial myopathies. The atrial pressure, again, the driving pressure is the key to early diastolic filling. Whereas in late diastolic filling, you have other parameters that are challenging: cardiac rhythms, ventricular arrhythmias, PVCs, atrial contractile function. Like I said, if you have an atrial myopathy, heart rate is a big problem because heart rate can actually merge together your E's and your A's, making it very challenging to find the difference between the two. Things as simple as your first degree AV block can also affect it because it'll change the timing of filling of both of those chambers, either left ventricle or atrial kick. In true, Spider-Man pointing at Spider-Man, the ventricular diastolic function will have a problem with the ventricular diastolic function. So what do we do about this? Well, like most problems, the best thing to do is bring in the Greek and figure out what we can do to find a difference. And it turns out that many people smarter than this particular Greek were able to find how they can see the pressure changes in early diastole to make an assessment of what of LV stiffness would be elucidated. So what do I mean by that? Well, so as we can see on the little middle picture here, there is a slope of the line of the red line, the LV pressure changes, and there's a slope. The slope is defined as the rate of change of pressure over time, or dP dt. And so what they can do, and what they figured out, is they can actually put in high fidelity catheters, and I believe Dr. Connolly and others have been doing this in our own lab, both with pressure volume loops as well as estimating tau, is trying to find a very, very good tracing of the changes in your left ventricular and diastolic pressures, or the isovolumetric relaxation phase. And you can guesstimate based on that the change of pressure, which estimates the change of stiffness. Now, the problem with that is that it's very difficult to do, all right? So dPdt requires a lot of very careful catheter manipulation. It requires very, very high frequency sampling to get you a nice smooth contour to really guesstimate, or really kind of draw out what is your rate of change of pressure. And so initially the studies looked at just looking at dPdt, but what they found out was that that is actually not only challenging, but it had its own issues because we're measuring a rate of change of pressure, and pressure, like we said, will actually have a large impact, both of the driving pressure of your gradient, LA to LV, and other parameters. But what they looked at, and what they really smartly kind of figured out, is not only can we look at the change of pressure, but we can mark a time constant that is related to the largest or most negative or the biggest negative slope of your left ventricular pressure curve. All right, so you mark time 0 as the most negative part of that curve, and you measure the time it takes to get to your first part of your filling. And what you can find from that is you can find something called a time constant, which they call tau. And so on the right, from a paper from 1979, I believe, this is the actual tracing of a single representative beat that they did in a heart that was hooked up to a lot of pressure, a lot of manometers, as well as a dog, and they did this in canine hearts. And what they found was that there is a linear logarithmic slope to the line that they are now calling tau. And so they've found a way to measure a time that is a linear, albeit exponentially linear relationship with pressure. Okay, that's key. Because what they really have found is they found a way to remove all of the confounders of pressure, driving pressure, LA/LD pressures, transmitral gradients, and be able to distill it down into a time constant. Okay, and that each time constant is different for every patient. But what we can see is that there is a linear, or rather an exponential relationship between pressure changes and this time constant. And that's important. Okay, because in this paper, the hemodynamic determinants of the time course of fall in canine left ventricular pressures, they were able to kind of prove a couple of important things. First is that they can measure it, okay? Much to their dismay, it was painstakingly difficult, but they were able to measure a time constant and derive a tau based on the slope of the line of that logarithmic pressure change difference. They also started to manipulate to the cardiovascular system to see if there's anything that affects tau, okay? And what they found was, and this is important, they found that tau was independent both of heart rate and preload, okay? They did find that there is a change in tau based on contractility. So they gave the dog hearts, epinephrine, they gave them acetylcholinesterase inhibitors. They tried to manipulate the contractility of the heart in any way possible, and they found that there is a change in tau. So tau does change with the cellular conditions of excitation, but it has nothing to do or has no change in your preload or your heart rate. And because it's so independent of your preload, separate to what we had seen previously with your E waves and your A waves and how they change depending on your preload, this became the gold standard, right? So the gold standard for assessing LV relaxation is tau, which is the time constant for LV relaxation. So then, any of you guys who are still listening to me are asking yourselves, well, why am I talking about this time constant? I told you it's really hard to measure. No, I'm pretty sure that most people haven't heard of the tau of their last patient that they saw or know what the time constant is. And so that's why a lot of people who are much, much smarter than me were able to do some more tests and figure out an interesting relationship between tau, which we know is an independent time constant that has nothing to do, it doesn't get affected by preload, and is a good marker of LV stiffness or an LV relaxation. And they measured it against, and they did a lot of Doppler measurements, but one of the Doppler measurements that they found was they can plot it against this E prime, or mitral annular velocity. And so when they did that, and they looked at so there's many trials here. You can see there's 4 or 5 trials at the bottom of this slide. But what they found was that there was a linear and inverse relationship between tau and E prime. And so many of you will be like, okay, well, who cares? Well, we care because E prime is actually something that's very easy to measure, or relatively easy to measure, and much more relatively easier to measure than tau itself. And so based on the fact that there is a negatively linear relationship between the two, and we know that we can measure E prime, we can start using that against our gold standard of tau. That's why tau was so important, because it is the gold standard, but we have something that correlates well with it. So that's a neat little trick to try to figure out, if you think about it, what we're trying to do is we're trying to figure out what the filling pressure of the left ventricle is, but we're using some fancy techniques to figure out a little bit, not only of the pressure changes, but of the tissue characteristics themselves. So it's really kind of cool. And so then we get to this idea of this E prime, all right? So E prime is the mitral annular velocity. Now within this talk, there's gonna be a combination of two different things. It's gonna be E prime, which is gonna be a combination of your lateral and your medial mitral annulus, or E prime as capital E prime, which could be your average E prime, okay? Both are important. The recommendations from the guidelines would recommend to use the average over just one or the other, but we'll get to that in a little bit. What we see though, and importantly, this is the other part of that chart that we saw. So on the top, we showed that E's and A's, so the inflow velocities of both your E wave and your A wave are dependent on your preload, whereas in the E prime velocities, they are independent of your preload. And that's huge, right? Because what happens is we want to figure out what the filling pressure of the heart is, but we don't want to turn all the little knobs that are necessary to understand the loading conditions of the heart. And so we know that we can do it regardless of the loading conditions. And in fact, you can use your E prime velocities even if you have atrial arrhythmias. So E prime velocities and E over E prime velocities, which we'll get to, actually correlate quite well with left atrial pressures, even in the presence of atrial fibrillation. So they're a very strong marker of diastolic function, independent of the ambient preload that's available. And so then how do we do this? All right, so I guess for those who haven't had a chance to put a probe in their hand, we go to our apical 4-chamber view, our transducer is at the apex, and then we put our sample volume for our pressure wave using some Doppler techniques, both at the annulus of the medial aspect of the annulus of the mitral valve and the lateral aspect of the annulus of the mitral valve. And it's important, the position is important. Putting that sample volume in the septum will likely round out your E prime, so it'll become less apparent as to what their maximum E prime velocities are. And if you put it too close to the leaflets, you'll see some noise. And if you change your gains, you'll see some over or under damping. So it's an important aspect. Similarly, you can put your sample volume at the tips of the mitral valve leaflets, and that's how you're going to get your E waves and your A waves, or your E to A that we see on the right. So on the right, we see three pictorial representation. The first one at the very top is what you'd see on catheterization. It's your normal left ventricular pressures that go below your left atrial pressures. The mitral valve opens, there's filling, and then there's the atrial kick. That's that first top left bar, okay? Then the next one is as your diastolic failure increases in its grade, you'll see there's changes to your left ventricular pressure waveforms. And similarly, like we saw, we're going to drive changes in your E and your A's. So you have your E and your A at the very left, which is showing you the normal pattern, and the large arrows that are right at the bottom of that line are telling you what your isovolumic relaxation time is, because that's the amount of time that you're going to sample your dPdt to get tau. And as you can see, as your relaxation as your diastolic grade increases, your IVRT, your isovolumic relaxation time, is going to change. It's going to widen, then it's going to go back to normal, then it's going to be smaller, okay? And similarly, your E's will go up, and then we'll go down, and then we'll go back up again in a pattern that's well described. Similarly, on the bottom, though, you see your E primes and your A primes. So EM is your tissue Doppler, and it correlates well with your E's. So you have that E prime, which doesn't change necessarily with preload condition, but it does change with your diastolic grade. So the restrictive filling pattern on the very right has a very small E prime. The normal has a very normal E prime. Again, we don't have a scale here, but you can see relative to one another, they are different. So that's kind of conceptualizing how we can figure out, both based on your E and A velocities. So your E velocities are going to be your filling of the left ventricle, but your E prime is going to tell you a lot more about your tissue characteristics of relaxation and stiffness. Okay, so think about it as your E's and your A's are talking about flow and pressure, whereas your E primes are talking about the tissue characteristics of relaxation. So they're kind of not looking at exactly the same thing, but they are very much related. So let's take a little intermission for a second, because that was a lot of information. And we're kind of a little more than halfway, so don't worry for anyone who doesn't want to hear any more about this. So diastolic function at the cellular level is an ATP-dependent process. Your inflow velocities have too many variables that can affect your E wave and your A wave, so they're not really good at it as a surrogate marker of filling pressure. Tau, the LV relaxation constant, is helpful because it's independent of loading conditions, but it's also painstakingly difficult to measure. Your mitral annular velocities are helpful because they are also load independent, and they correlate well with tau, which we know is how we can see the stiffness of the ventricle. And we can use both the inflow velocities and tissue Doppler to get an estimate of your filling pressure. So diastolic function. I guess the bigger picture is this. Okay, so in diastolic function, this is straight out of the guidelines. We have your normal LVEF diastolic function on your left, and we have your mitral inflows on the right. And the mitral inflow velocities, and we'll get to this, but I think the key thing that I wanted to point out is we're going to focus in on that little box in the middle there, okay? Because those are what we believe, and we've already touched base on some of these, but those are what we believe to be the determinants of diastolic function or dysfunction as a surrogate marker of filling pressures, of left ventricular filling pressures, okay? So we're going to go and break these down. We're going to talk about E over E prime. We've talked about septal E prime and lateral E prime velocities and how they correlate well with relaxation. And then we're going to talk about TR velocity and LA volume. And then we're going to briefly touch base on the right-hand side, okay? So E over E prime. Okay, you heard me talk about E. You heard me talk about E prime. Now we're going to talk about the ratio of E and E prime. And so we're going to talk about E as transmitral flow, not mitral flow, transmitral flow. And I can, this is more of a trust me bro situation, but you will understand that there are a lot of studies that looked at the correlation between your inflow velocities or your E velocities and heart failure. And it turns out that E velocities can correlate, again, with the caveats of filling pressure, actually correlate relatively well with patients who have reduced LV function. So we can, the patterns that we discuss, normal patterns, pseudo-normalization, restrictive pattern, etc., can actually correlate quite well with patients who have heart failure. So the higher, I guess, stage or grade of heart failure, the more changes you'll see in your E transmitral flow and your filling parameters, okay? But what they found was that the transmitral, I don't know, this must be an autocorrect, but the transmitral flow is actually proportionate both to the ratio of your LA pressures, okay, and the relaxation constant tau that we talked about. And we're going to park that for a second. So we know that they're proportional, okay? Now, mitral annular velocity, we just discussed at length, and we found that it is inversely proportional. So your E prime is inversely proportional to tau. Now, we could do a little bit of back of the envelope, rough and dirty mathematics and find out that if your E is proportional to LA pressure and tau, and your E prime is proportional to 1 over tau, then E over E prime is actually proportional to your LA pressure. And that's something that actually pans out really well, okay? So whenever you're looking at an echocardiogram and you're looking at the report, which we almost never report as, the E over E prime is a good first place to look at, well, what do I think the left atrial pressure is doing? And the surrogate there, the left atrial pressure is a surrogate of left ventricular and diastolic pressures, presuming that there's no mitral stenosis or other problems with your mitral valve, okay? But it's a key parameter. It is proportional to your left atrial pressures. And in fact, they've done many validated models to figure out formulas to try to extrapolate what E over E prime values would look like for actual pressure changes, like millimeters of mercury. And so they say that if you take your E over E prime and you add 4 to it, that is going to be a safe bet on what you think the left atrial pressures are going to be like. Interestingly, all those studies looked at a cutoff. So they were saying that any E over E prime that's less than 14, we're going to dictate it as normal, okay? And any E over E prime that's over 14 is going to be abnormal or elevated filling pressure. And that's in fact one of the cutoffs that we were looking at before. You can see your E over E prime of 14 is one of those first divergent points on that left box in the middle there. And so they, again, this is kind of hammering the point home, but what they found was that on the left is going to be your kind of area under the curve, or the receiver operating curve for your E prime, and so your lateral E and your septal E, and how it correlates with left atrial, so the mean left ventricular diastolic pressures. And you can see that it actually correlates quite well. And in fact, this is one of the reasons that they're talking about using the average lateral and septal, because the area under the curve for that would actually be quite high, which is good. Which is what we want. We want this to be, the area under the curve to be high, because it tells us it's going to give us a good sensitivity and specificity, and it means that the test is good. It's a good test. On the right, you'll see that they've plotted again this receiver operating curve for the prediction of MLVDP, which is mean left ventricular diastolic pressure is greater than 12. And they plotted it for different parameters that they were able to find. And as you can see, the solid line at the very bottom, the septal E over E prime, in this particular instance, had the highest area under the curve. So it was the best test, all right? It was the most predictive test as a combination of the balance between sensitivity and specificity. The next best after that was Valsalva, looking at the changes of E's and A's with Valsalva, which we're not going to get into. And then after that, it was E over A. All right, so the important part here is that E over E prime is a good correlate. It's a good test. It has good receiver operator curve predictions for an elevated left ventricular end diastolic pressure, okay? Now, the next part of this was the left atrial side. And so if we flip all the way back, we'll see that we talked about the E over E prime, we talked about your lateral and your septal E primes, and now we're going to talk about your LA volume index. And in fact, and quite simply, there was a change. So patients who had higher diastolic grades had higher index left atrial volumes, and it correlated linearly. Now, in this particular instance, on this slide from JO from the Mayo Clinic, you'll see that they only had 147 patients, but there was a good correlation. So the R value is 0.78, and in fact, the higher the grade, the higher the left atrial volume index. And that's another important surrogate marker to talk about filling pressures, or left ventricular end diastolic pressure. Lastly, we're going to talk a little bit about TR velocity. Okay, so it's helpful in assessing TR velocity. The TR velocity is helpful in assessing the diastolic function because we're using it as a surrogate marker. It's a surrogate marker of mean left atrial pressure. If you guys remember the big man from Basel on my last physics talk, with 4v squared, you can take your speed, your velocity, and you can translate that into a pressure. And that pressure is going to be a surrogate marker for your mean left atrial pressure. This assumes that there's no problem in between. No pulmonary disease, no pulmonary stenosis, nothing in the way, which again is a lot of caveats to this, right? This parameter, though, like we all know, TR velocities and TR pressure, right ventricular systolic pressures, are very load dependent. All right, they're very dependent on the loading conditions of the right ventricle, the volume status of the patient, and in fact, we decongest a lot of these patients. We give them diuretics to reduce their end diastolic pressures, and in so doing, we are affecting both the TR velocities and TR pressures indirectly. So think about it as another layer of telling you that there's elevated mean left atrial pressures, but it is absolutely not one of those things where if you don't have the high TR velocities, that they don't have diastolic function. And in fact, in any of the parameters, the guidelines even specifically say there will be instances where you're going to have a mixed bag of normal and abnormal findings because none of them are really good in unison on their own. You have to put all of those together. And the one that we commonly see that is kind of lower than what we would expect that are unhelpful is the TR velocity. And then again, it's a testament to the medical therapy. So in the last final few moments, I'm going to talk a little bit about this right panel here. But I want to pause for a second and kind of give a 40,000 foot view of how this diastolic function should be assessed. The left panel, all right, or the one that says in patients with normal left ventricular ejection fractions, is purely a screening. It is trying to figure out, do I think they have normal filling pressures or abnormal filling pressures? And as you can see on the left, so really the forget the indeterminate in the middle, because that has to do with the fact that there's nothing good to correlate all those parameters together. We're really diverging to, do I think all those values are normal, or do I think they're abnormal? And if they're abnormal, you move to the second part, which is evaluating the mitral inflow, the panel B on the right. Okay, so think about it as first step, is it normal filling or abnormal filling? There may be an indeterminate because we have parameters that are kind of arguing against each other, but that's really what we're looking at on the left. Okay, on the right, we're looking at different parameters to kind of tease out what the left atrial pressures are like, and we do it in two layers. The first layer is, what are your E's and your A's, okay? And how do they relate to each other? Because we talked about, so the right panel is conventionally done in patients with abnormal EFs, but they can be done in patients with normal EFs, but evidence of diastolic dysfunction. And we know that in patients with abnormal EF, I told you before, the E's and the A's can actually correlate quite well in certain ways to filling pressures or to estimates of filling pressure. So the extremes are what we're talking about. The very left first box, so the E over A less than 0.8 with a low E velocity, less than 50, is pretty much going to be your normal left atrial pressures, okay? Abnormal left ventricular ejection fraction, but normal left atrial pressures. So the filling pressures are normal, even though the rest is abnormal. Then on the very right, the other extreme, you have your E over A greater than 2, previously known as restrictive filling pattern. And what it's telling you is that the E's are really, really high and the A's are really, really low. And that has to do with the driving pressures of a failing heart, okay? So it's gonna be a short, big E, and then you're going to have a very small A, and both of those together are going to give you a high ratio. And so we know that that's going to be a very elevated left atrial pressure, or grade 3 diastolic dysfunction. Okay, I hope everyone's with me. So the first panel on the left, is it normal or abnormal filling? The panel on the right, if it's abnormal filling, how abnormal is it? Well, we'll do it first by your E's and your A's. Then there's the middle bit. Okay, so we know the extremes are normal and highly elevated left atrial pressures. Now we have to figure out what's between those two. And we're going to use a combination of what we already discussed. Your E over E prime, which again is a surrogate marker of your left atrial pressure. Your TR velocity at 2.8 meters per second, or 30 millimeters of mercury, which is going to be another surrogate marker of your left atrial pressure. And your LA volume index, which again correlates well with heart failure and diastolic dysfunction, or grade of diastolic dysfunction. And those three parameters are going to help us differentiate either normal left atrial pressure or grade 2 diastolic dysfunction. Okay, that's the essence of it. You know, there's the minutia of all the numbers, but really what you're doing is normal or abnormal filling. And if it's abnormal, how abnormal is it? Is it wildly abnormal or normal? And if it's not any of those two, then we can use parameters to say it's in between the two, or normal. Okay. And, you know, thankfully, this is not a big talk because diastology is a difficult talk to talk about. But these are a couple of the pitfalls that you could think about when you're talking about, measuring someone's diastolic function. And again, there's a lot of caveats. This is not an exhaustive list. This in no way isn't an exhaustive list. But these are the things that we see very regularly, which are going to hinder our assessment of diastolic function. So anything that gives you annular dysfunction, that can include mitral annular calcification, mitral annular prostheses, mitral valve prostheses, prosthetic valves. If you have patients who've had some form of annular issue, like rheumatic, all the things that can affect your annular function will affect your diastolic function. Because again, we're using those normative values as our E over E primes. And if you have valvular dysfunction itself, so moderate to severe mitral regurgitation, all of these things start to go out the window. You can have relatively normal filling pressures, but your E over A's can be greater than 2. You can have crazy filling patterns. It really is a matter of the transmitral flow. So it's not really helpful in those conditions. And then arrhythmia. So like we said, atrial fibrillation previously is one of the biggest ones, because it affects, not only does it affect the left atrial volume, it affects your filling, it affects your annular velocities, it affects and your TR velocities. All right, so it affects a lot of things, which is going to be really difficult to assume that we know what the diastolic filling pattern is in. However, as I said previously, in patients who have atrial fibrillation, your E over E prime is still a good surrogate marker, or can still be a good surrogate marker for left atrial pressure. Things like first degree AV block can affect your filling pattern of your A wave. So if you can imagine, and that patients who have first degree AV block, their P waves and the electrical P wave and the mechanical depolarization of your atria are going to be happening well before the end of diastole, and that can cause a whole myriad of changes to how your diastolic function and filling transmitral flow looks like, and what the end diastolic filling looks like. High-grade AV block, another classic example of how you can dissociate the E's, the normal E's and the A's, and it'll give you an issue with interpretation. So all is that to say is that we spend a lot of time figuring out subtle ways to evaluate diastolic dysfunction, but there's a lot of caveats to it, a lot of ifs, a lot of no problems with the mitral valve, no problems with the annulus, no problems with the arrhythmias, no problems with the lungs. There's a lot of no problems. But it is the best that we can do. And it is quite helpful because diastolic function actually correlates quite well with outcomes. Now, that being said, I'm not going to get into that. I'm going to park it there because I think that it's quite a dense talk. So I thank everyone. That's my daughter. If everyone can be as chill as she is, eating her little hops while she's drinking some water on the couch, then diastolic function will prevail. Thank you, and I'm happy to take any questions.
Certainly, she appears very relaxed and is very glad that all the Greek people have answers to all our problems.
That's what we're here for.
Yeah, I just have to add, like, you know, this is all Chinese to me.
That's funny. Most other people say it's all Greek to me. So,
so any questions, comments? So maybe I'll just start it with one question. Like, you know, when you, like you alluded to, actually assessing of diastolic function is actually a two-phase process. So first of all, you say yes or no, and then if the LV dysfunction is abnormal, if there's LV dysfunction or LVEF is abnormal, then you will go to actually a second diagram, right? Mm-hmm. So what happened when you have like missing parameters? So for example, when you can't get the TLJ, or when you cannot, like, you know, measure the LA volume accurately, or you only have like AP dimensions and things like that. So can you sort of elaborate on that part?
Yeah, so that's another big challenge, right? And the common one that we usually get, for example, is you know, not enough TR to assess the velocities or the RVSP, and it is a challenge it's a technical challenge. So it's an aspect of the actual scanning itself. That being said, the guidelines do actually. Oops, sorry about that. The guidelines do actually talk a little bit about that. So on the right panel, for example, there are. You know, in the mitral inflow with the 3 criteria, there's actually a part of it that has 2 criteria. And it's saying basically, you can even use 2 of those 3 criteria to make an assessment of your diastolic function, although 3 is ideal. Similarly, it's the same on the left. You know, it talks not only about, it doesn't, the guidelines are specifically vague in that aspect. And they don't say, you know, 2 out of 4 or 3 out of 4 directly. They're talking about the ratio of positivity. They say, is it less than 50% positive or greater than 50% positive? And I think the reason they do that and they leave it open to interpretation is because none of these parameters on their own are helpful to make that assessment. You need to have a combined assessment. And even if you don't have all the parameters, let's say you don't have your TR velocity, but you have all the rest, you can still make an assessment of, is it 50% positive or 50% negative? Now, if you start to lose more, so you don't have a left atrial volume, you don't have the TR volume, and you really only are left with your E primes, then it becomes much more of a challenge. And it's really not a validated method to figure out the diastolic function at that point.
So one other challenging point is looking at the left diagram. And we often run into a situation of indeterminate. So, you know, so when you have, like, you know, only 50% of the criteria or 2 out of 4 positive on the left diagram, you go to indeterminates rather. So how do you deal with that when it comes to indeterminate? Should we go to the second diagram, or should we just stay in just report indeterminate?
Yeah, so that's a really good question. So really the indeterminate is basically saying that we kind of, based on the parameters, we don't know what the left atrial, or the left ventricular end diastolic pressures is. That's not to say that it's not, that indeterminate automatically means abnormal. It is to say that based on the parameters we have, we can't make an accurate assessment. Going from indeterminate and then using your E to A's is something that many advanced cardiologists would use. So they would say, well, okay, if we don't have, so let's say we're staying in the left panel here, normal LVEF, but indeterminate diastolic function. Many experts would say you could still visualize your E's and your A's and make an assessment of what you think the filling patterns may be like. That being said, it's not the 100% most validated way to do that, because we're starting from a position where we're saying, I don't know what the left atrial filling pressures is, but I'm going to ignore that, and I'm going to look at the transmitral flow and make an assessment. So there are caveats to that.
Fotis, it's
I think
Kim
you're muted
here.
there, Chi-Ming. Sorry. Oh, hey, Kim.
Oh, sorry. No, please go ahead.
Yeah, and I was just going to remind everyone that obviously Fotis focused on diastolic dysfunction, and just to remind everyone that this, like diastolic function is not the same as diastolic filling. Diastolic dysfunction is not the same as heart failure, preserved ejection fraction, but there is in the new sort of universal definition of heart failure, remember that you need to have a number of criteria, symptoms and signs, as well as an elevated BNP, as well as echo evidence of things that are abnormal that support the diagnosis. And that can either obviously be a reduced ejection fraction or a number of these other parameters like, elevated E over E prime and the abnormal diastolic function. So sometimes it's sort of forgotten that these are important prognostic factors when either the EF is low, but in fact, these are corroborating evidence if you're considering that diagnosis of HFpEF there. So it is important that obviously we have this approach where we report the LA volume and the TR velocity and the average E over E prime, because that might in fact change your diagnosis, along with the symptoms and signs and an elevated BNP there. So this is actually important. So don't forget the old diastology, and it is fun. There's no doubt about that. And just to comment about tau, one of the big issues we've always struggled with is really this load dependence of all the parameters there. And it is something we still struggle with. So tau was originally described as a load independent parameter. It is actually load dependent. It does vary with heart rate, as well as probably preload and afterload. And there's different ways you can actually measure it. But for practically, we don't really measure it outside the sort of research laboratory settings there. So you'll hear about it a lot, but it's not something you'll actually see. And the other, I think there was a question that just came up about the load in the loading conditions there in the chat, Fody. There was one about can you use a Valsalva maneuver to assess the changes in the EIA pattern. I wondered if you wanted to comment on that.
Yeah. It's actually really interesting. I had a couple of slides, but I took them out because they were a little bit more challenging to interpret. But you can actually use, so one of the parameters that you can use is using the Valsalva maneuver to differentiate a pseudo-normal pattern from a normal pattern. So if you have patients who have an E over A that's in a pseudo-normal filling pattern, you can actually use the Valsalva maneuver and see if the changes in your E waves is greater than 50%, then you can actually say that it's actually normal left atrial pressures and not a pseudo-normal pressure. So again, Valsalva maneuver is going to change your preload and in preload conditions, both of your right side and your left side, and that's really what you're kind of doing. You're isolating the pressure changes at an instantaneous time with your Valsalva, and you're making a kind of de novo view of your mitral inflow. or post Valsalva, you're looking at your E and your A wave patterns and how they are changed with your loading conditions, which again is going to be helpful to tease out some of those pseudonormals from the normals. I'm looking at the chat here. Sorry, Kim, did you have anything you wanted to say about that?
Yeah, I was just going to add to that back in the old days, we used to talk about the restrictive filling pattern, and then there was a fixed and non-fixed pattern, which is if your EO was greater than 2:1 and it didn't change significantly with the Valsalva, then that was actually evidence of much higher left atrial filling pressures and an even worse prognostic indicator. Same concept exactly as you've said, Foti, but there was that older categorization. It's sort of gone out of favor now because I think we've got a better integrated approach to look at diastolic filling, but you can still do it. There's no harm in doing the Valsalva there and seeing if it changes, because it is helpful clinically, because that might then, suggest that, you should increase your diuretic dosage and decongest further. So sometimes it is helpful.
Yeah, of course. Yeah. I'm just looking at the chat here. So Dean says, how about pacemaker? Yeah, so pacemaker activation can also affect your depolarization, so your tissue depolarization. While it's not commented specifically, like there are a lot of pathologies that they talk about, the guidelines do recommend that if you are someone who's getting paced all the time, that your diastolic function may be, the assessment of your diastolic dysfunction may be limited because of the activation of the pacemaker, presumably from the left apex. It becomes a little bit of more of a challenge where you have patients who are coming in, they have His bundle pacing, and they're actually using more of their normal conduction system. I don't have an answer for that. But in general, I think anything that's going to be affecting how your ventricle normally depolarizes, pacemaker, junctional escape beats, what have you, it's going to play a role in your tissue Doppler. It's going to play a role in your assessment. It's going to break down some of the assumptions of your assessment of your diastolic function. Kathy says here, can we look at the pulmonary vein Doppler pattern to comment on LA filling pressures? Yeah, so it's another aspect of this that's not, it's in the guidelines. It's not within these flow diagrams, but you absolutely can. It's from what I've read, and please, anyone who's on this call can correct me if I'm wrong, but from what I've read, it's good in its extremes. So if you have an S and a D, so for those who are talking about, who might not understand it as much, the pulmonary vein patterns, you're looking at basically three parameters, your S, your D, and your A. And it's basically saying that there's going to be flow into the left atrium during systole, during diastole, and there's going to be a reversal of flow in the pulmonary veins due to your atrial contraction. And so they found that if you map your S and your Ds, the ratio, the S to D ratio, and your ratios are predominantly more systolic, or so the S is much bigger than the D, vice versa on other things if you have reversal of flow. But if you have S greater than D, you're more than likely to be in a situation where you have normal left atrial pressures. And in essence, it's another marker to tell you that you have normal filling pressures of the left ventricle. Whereas it starts to become much more challenging when your S and your D ratios become similar, your S becomes blunted. There are a lot of parameters that can affect that, because it's not only the stiffness of your left atrial and your left atrial filling, it has to do with volume, driving pressures, it has to do with any other valvular dysfunction. And then we're not even going to get to the point of talking about how we can look at how the high left atrial pressures can affect the pulmonary vascular resistance, which is another thing. But I agree, Kathy. I mean, I think encouraging people to optimize the pulmonary vein flow is helpful because, again, it's another tool that we have to kind of assess, do I think this is normal or not? You know, it's kind of it's if you can conceptualize a chart above this chart that's talking about, well, if your S and your Ds are normal, then you're pretty much going to be, you're going to be okay.
Well, thank you so much.
Fotis, hey, Chiminga, it's Bob Howard. Just a question about the left-hand panel, the patients with normal LVEF. I mean, there's a group of patients that have a normal EF, but they have an abnormal heart. So, you know, they got the easy one is LVH, lots of different reasons for that. And I think there are some people who believe that if the E over E prime is greater than 14, and you have LVH, your diastolic function is probably not normal, regardless of what the TR velocity, the LA index is. So this notion that diastolic function is, I guess the other way to say this, if you look at the right panel, all of these people, all of these patients have an abnormal heart. So we're actually, they all have diastolic dysfunction. We're just trying to predict what their left atrial pressure is. On the left, there are those who might have a normal left atrial pressure at the moment we're studying them, but they actually have diastolic dysfunction. And so so it might be useful to know, if you're a clinician, that your patient has diastolic dysfunction, even though their LA pressure might at that moment be normal. And so that opportunity, right? So if, say you have somebody with LVH and their E over E prime is greater than 14, and then, you don't get a TR and there's no, the LA, whatever, isn't big, do they have, I think there are some people who would say they probably have diastolic dysfunction. LA pressure, we maybe not be able to comment on, but we can say they have diastolic dysfunction. Comments on that?
No, I agree completely, Dr. Howard. And, and it's funny because the guidelines actually, they have a part, there's like a couple of chapters on the special populations. One of the special populations is exactly those. It's those patients who have the essence of normal EF, okay, which again is not, I have my gripe with this is I don't know why we're starting from a normal EF. It's, I guess they have to choose something normal, but it's really basically saying we have no huge abnormalities in the systolic function of the heart, but like you mentioned, there could be structural changes to the heart, which aren't necessarily correlates of systolic function or dysfunction. And so I completely agree with you. And in those populations that they talked about, HCM, LVH, patients who have advanced AV block, et cetera, they say exactly the same thing as you said. It's important to differentiate those patients who have a structurally abnormal heart and normal EF, and understand that they may too have diastolic dysfunction despite the fact that their systolic function is normal. I think back always to when I first started learning about diastolic dysfunction, and I was rounding in his TCU way back when, and my fellow said, well, does this patient have diastolic dysfunction? And I said, I don't know. And he says, well, you do know. If they have systolic dysfunction, they by definition have diastolic dysfunction. But I think that I've expanded my knowledge to understand that the systolic dysfunction is not the only reason you can have diastolic dysfunction. And I agree with you that these markers are there in a vacuum based on just looking at no valve issues, just looking at myocardial performance, et cetera. So completely agree. I think E over E prime is the thing that I took away from this, saying I think it's the best surrogate marker of your left atrial pressures. And I think based on that, we should be informing clinicians that they may have a structurally normal a physically normal ejection fraction, but they may not have normal diastolic function, or they may have diastolic dysfunction.